Good evening, everyone, and welcome to County Durham and Darlington NHS Foundation Trust Annual General Meeting for 2020. I would like to thank you for joining us this evening and participating in our first public virtual meeting, either through our live event access or through the YouTube channel. The use of this technology for a meeting of this scale is new to us, so I do hope that you bear with us and that we do not experience any technical hiccups. I'm joined this evening by colleagues from the board, Sue Jakes, Chief Executive, and the other executive colleagues from the Trust. I'm also pleased that we are joined by our Trust Lead Governor from the Council of Governors. The meeting will be similar to our normal format. In a few moments, I will review the minutes of last year, as well as any matters arising from the minutes. Just to let you know that tonight, despite being recorded and live, the minutes will still be taken, but they will not be verbatim, but just the essence of the discussion and dialogue that takes place. You should now be able to see a copy of the agenda for tonight's meeting. Once I have reviewed the minutes from last year, I will hand over to Sue, the Chief Executive, who will then give a presentation on the remaining items on the agenda. There will then be a short presentation on our Foundation Trust membership over the past year. The purpose of our annual general meeting is mainly to reflect on our performance over the last financial year. But in light of the unprecedented nature of what happened in January of this year, there will be a lot of reflection on the essence of our business since January of this year with the implementation of COVID-19. We have received a number of questions in advance. Thank you to those who have sent those through. We will answer these questions first. They will be read out with a response from the respective executive director. During the course of this event, you can also submit a question should you wish. To ask a question, please use the live question and answer function. You will see this marked by a speech bubble on your screens. Please type your question into this box. We will be reviewing these questions and then publishing them so they become public for everyone to see. Due to the constraints, though, we may not be able to get through all the questions this evening. So any questions that we don't get around to answering will be responded through our webpage or on the website respectively. The questions with the most likes will be the ones we will answer this evening, and we will ensure that the remaining are answered in a few days or on the AGM website. There will be a cut-off point for the questions we will take this evening. This will be taken when we begin to answer the questions received in advance, and I will advise you in due course when the cut-off point is going to take place. Normally, we would have our patient experience team present at the annual general meeting for us to direct our members or the public to, if so needed. Due to the format this year, any questions we have received which relate to episodes of care or specific individual circumstances, we will respond details to our patient experience team who are better placed to help with this type of inquiry. So now I will move to reviewing the minutes of the last annual general meeting in 2019. These minutes will appear on our website, but for the purpose of accuracy and any matters arising, I will take those as we move through each of the pages. Before I move on though, I would like to pay particular reference to Ethel Armstrong. Ethel was one of our governors for a number of years. Ethel has lived all of her working life and indeed her retirement life working for the NHS and indeed her retirement colleagues for many years thereafter. So I would just like to acknowledge our due respects to Ethel. I would have attended our service, but COVID restrictions did not permit me to do so. On any matters arising or inaccuracies on page 2, page 3, page 4, page 5, or page 6. If not, then I will move to Sue, who will give the presentation with regard to performance last year. Thank you, Sue.
Thank you, Chairman. So for anybody who's due to go and doesn't know much about this, I'm going to start with a little bit of background. We are the largest NHS trusts in the country. We serve a population of 650,000, which, to give you some context, sits in a northeast population of about 2.7 million. And not surprisingly, therefore, we provide more healthcare to the people of the northeast than any other trust, and indeed deliver over 2 million patient contacts each year. We provide care within the hospital, both acute emergency care and hospital care. We're also significant in the health and wellbeing offering that we make. So we work very closely with our local authority partners to try and provide and support our populations to stay as healthy and well as is possible. And we outreach significantly into the community, providing services such as matrons into support some of the care homes, and district nurses supporting people in their own home. As you'll see from the slide, just a couple of really interesting statistics: over 735,000 district nurse appointments during the course of 1920, the year that we're considering, and over 500,000 outpatient appointments. So you'll see the reach from that slide of the services that we provide. If we move on to the next slide, and as the chairman's already referred to, this has been a very 1920, a rather exceptional and extraordinary year. And when we think back to everything that COVID has required us to respond to, the outbreak and the first reports of that in Wuhan, China, were back on the 30th of December 2019. It was back on the 31st of January 2020 that the first COVID positive cases were reported in the UK in the North East and Yorkshire region. And on the 11th of March 2020, the World Health Organization declared COVID as a pandemic. We've clearly, in the latter part of last year, had to respond to this, and done so exceptionally well through the good offices of our staff. If I move on to the next slide, I'll share with you some of what we needed to do. We had to change services really quickly. We had to deal with COVID patients, and we had to make sure that we protected patients who didn't have COVID. We got huge support from our local communities, everything from businesses sending in food parcels for staff who were working incredibly long hours in an incredibly dedicated way, through to companies that at the very beginning were helping us provide the PPE that our staff needed by creating it on 3D digital printers and everything in between. We've received huge benefits and gifts through our charity and through the national NHS Charities Together, and all of that has provided our workforce with a significant boost at a time when they were dealing with an unprecedented and, right in the early days, very unknown disease. During the peak of COVID-19, the Trust and our partners in health and social care and independent partners continued to maintain services for urgent cases, urgent operations for cancer patients, and urgent non-elective patients, and through pathways for non-COVID patients, ensuring that they were kept separate from anybody who had contracted COVID and was in hospital. This has left us well placed to recover and resume services in line with national guidelines. In terms of the key changes on the next slide, these are some of the things that we had to put in place to achieve what I've just outlined. We had to separate COVID and non-COVID patients, which meant that each of our ED departments, our emergency departments, had to be split into two. We had to significantly expand the footprint of each, and we are extremely grateful to the staff that led that work and to the contractors who helped us literally expand the DMH site to be more than double the size of that it was before COVID. We unfortunately did have to postpone some non-urgent planned operations and outpatient appointments to ensure that we could deal with both the COVID patients and the emergency workload, and that we didn't affect those cancer treatments and urgent clinical care that was required. Our intensive care departments came under significant pressure, and both of them doubled in size and were accommodated in our theatre suites. And you can see in the picture there some of our theatre team showing the efforts that they had made over the period of COVID. We're very lucky to have a wide-ranging community offering, hospital offering, and we were therefore able to put additional ward capacity into Bishop Auckland, and I'll come to that later. For our patients that had chemotherapy, that same community estate allowed us to move them out of the Darlington and Durham sites where we were seeing most of our COVID patients to Bishop Auckland and Shotley Bridge, keeping them safe from all the possibilities of picking up infection when they were in that compromised state. We did unfortunately have to suspend our endoscopy services. This was in line at the time with national guidance, but as you'll hear later, we've been able to stand those services up again. We rolled out plans that restricted visiting in hospital, increased good hand washing practices, and rearranged face-to-face appointments where we were able to either by telephone or video. So we were doing everything we possibly could to keep patients safe at all points during the pandemic. This slide details for you the numbers of COVID admissions and the very unfortunate number of COVID deaths that we had within our trust over the period from March through to August of this year. As you'll see, there were 299 patients admitted to DMH with COVID and 473 to UHND. UHND is a slightly larger hospital and serves a bigger catchment. Many of you will be familiar with some of the demographics that we now understand about COVID. So what we saw in terms of those 227 patient deaths was 134 of those were amongst males and 93 females. 24 of the patients who sadly died were aged 18 to 64. 127 of them were aged 65 to 84 and 76 were aged 85 plus. We only had 3 under 18s admitted and we had no deaths amongst that group of 3. 63 patients sadly died in DMH and 128 in UHND. 36 sadly passed away on our other sites. In terms of our response to COVID, as a major incident, it meant that we changed all of our governance arrangements to work with the local resilience partnerships. We stood down non-urgent meetings and we set up 7-day working right across the trust for both the management and clinical. We had a gold command arrangement in place that met daily, and through that arrangement we were able to support the staff within the organisation and the clinical teams that were working on the ground. 7/7 working became the normal for executives, senior managers and matrons. We had a significant presence across all of the different sites. We provided daily bulletins on coronavirus. The guidance was changing significantly, so it was important that we had really good communication, and we know from our visits to the various wards and departments that they were very well received and indeed continue to be. There was a twice weekly chief exec briefing for the non-executives and lead governor, and the chairman and I spoke each and every day, and that continues so that he could be completely up to speed with everything that we were doing. As I mentioned earlier, we had the benefit of some estate at Bishop Auckland Hospital, which we converted to increase our bed base, which we were able to increase from 1,106 beds to 1,376. And this was a real luxury compared to some other organisations that had significant restrictions on their sites. We were able to expand the critical care provision and at points double that, and we were strengthening the medical management rota. That was led by 3 of our recently retired consultants who returned to practice, and many other staff who'd recently left the organisation were kind enough to come back, wanting to help with the effort to make sure that we could serve our communities well and keep our patients safe and treat patients with COVID to the very best of our abilities. In terms of the services, as well as having the 2 streams running through each of the A&E departments, we split our respiratory services into 2 separate pathways. Those pathways essentially ran right throughout the organisation, so that at all points in a patient's journey, those patients that either had confirmed or suspected COVID were kept separate from those that were COVID-free. Inevitably, this meant that in terms of the elective work that we had to pause and stand down, we have seen an increase in the number of patients that have been waiting over 52 weeks for treatment. We've worked successfully with the independent sector to try and deal with those patients through a nationally led government initiative, and also every single one of those patients has been and is continually being reviewed to ensure that they are coming to no harm on that waiting list, and if their clinical priority changes, they are brought forward in terms of their position on the list. Moving to the next page, we were able to ring fence our paediatric and obstetric provision, and despite having to make real restrictions on visiting to keep both visitors and our patients and staff safe, we did significantly benefit from iPads that we introduced across the organisation to allow patients to contact their relatives virtually where they were unable to use their own phones or tablets. We had a stay in touch service that enabled relatives to email messages that could be taken to patients. So we tried our very best in very difficult circumstances to keep that good flow of information between patients and their loved ones. In terms of our staffing, we determined to introduce COVID testing on our own sites. We redeployed staff that were not needed for some of the elective activities that had been paused onto COVID duties. We worked incredibly hard to ensure that PPE was available, both in terms of through our regional mutual aid arrangements, but also the procurement we were doing nationally. And through that, we're really pleased to say that at no point to our knowledge did any of our staff have to work without the PPE that at that time was advised. More latterly, the concept of COVID secure workplaces came in nationally, and we've been really forward in our thinking about how we provide those and how we keep our staff safe and have flexible working options for them. We provided free food in the early days for our staff who found it difficult to access food from other sources and were often working through their breaks. We provided car parking arrangements for staff that allowed them to both freely park in terms of not being charged, but also provided more space from which they could in which they could park rather. The release of final year medical and nursing students to the front line enabled us to further bolster the staff that were working on the ground, and I know from personally speaking to some of those staff that they hugely benefited from the contact with some of the more experienced staff that had returned from retirement. And through that arrangement, we were managing to essentially open up new wards with half teams from old wards in what we described as a Russian doll concept, so that at no time were staff asked to work with colleagues with whom they hadn't had opportunity to develop relationships and to undertake any necessary training for those staff that were working in areas which they were not ordinarily assigned to. We bought a lot more equipment. We spent a lot of time, and we need to give credit to our procurement colleagues, sourcing oxygen masks, ventilators, CPAP machines and NIV equipment. And at no time did we run out of any of that, which I think is a credit to their resolve to ensure that by hook or by crook, we were able to access everything that we needed. We established significant increases in our temporary mortuary capacity, which thankfully we didn't in the end need to use. And we worked very closely with GP colleagues who both came in to support the services in our community hospitals and also in our urgent care centres. So if we look to now, because I know you'll be interested in that, all of our services have restarted. It's on the next slide, yeah. We have got targets from NHS England and Improvement for increasing our activity levels. These are to be applied across the whole of England, and we are working hard on those now. In terms of our urgent and emergency care, whilst in the early days we saw the demand for those services drop off significantly, many people choosing not to present into hospital, activity now is back to almost levels before the pre-COVID, or back to pre-COVID levels. We've got pressures, as I've referred to, on 52 weeks, and we're working innovatively to try and do all that we can to ensure that patients can be seen as quickly as possible, but inevitably this will take some time, and our current estimates suggest that that won't be able to be put back onto an even keel until early in next financial year. We've been looking at our referral to treatment times, our pressure areas such as endoscopy, and putting additional capacity in to deal with some of the backlog that built up when those services were suspended. And very appropriately, I guess, given some of the national information that's being shared this week about the increased incidence of COVID infection and COVID hospitalisation, we've worked hard on our winter plan. It's a system plan that we've pulled together with our partners, and we've made sure that we can cope within that with a further wave of COVID infections such as we may need to deal with. And in doing so, are very conscious that we reduce health inequalities, supporting both our workforce and our patients. So having taken that slight diversion into everything that I know people will have been interested to understand around COVID, what did that mean for our performance? I'm going to take you through that at a very high level. So if we turn to the first slide, we'd experienced quite a lot of pressure on our A&E target during the course of the year, particularly the 95% 4-hour target, and we ended the year in a position of 79.5%. We've done a lot to try and ameliorate that, and interestingly, we've been aware that often the issues in the emergency department are due to flow elsewhere in the hospital, and indeed when we saw that flow operate very differently under COVID, we were able to secure 95% performance in each of April, May and June, although, as I've said, activity is starting to increase. So we're looking at how we can undertake activity differently, use technology, do and move from face-to-face consultations to telephone consultations where and when that's possible. So we're doing a lot of that already. Not all of it is counted in terms of the way that nationally activity in the NHS is counted, so we've put forward representation around that. The national target for referral to treatment times is 92% of patients to receive treatment within 18 weeks of referral, and we had a year-end position of 88.8%. Clearly that was impacted in those early days of COVID, and when we look at our position compared to that nationally, we fared relatively reasonably well, and certainly amongst our peers in the North East. Another service that suffered slightly from COVID, but where we appear to be relatively strong compared to some of our colleagues, was the cancer services. So the national target that 85% of patients have a maximum 62-day wait from the 2-week wait referral for suspected cancer to their first treatment. And for us, the 2-week wait, which has a target of 93%, we secured a performance of 89.73, and breast target of 93%, 83.75, and that 62-day target performance of 84.29. So that looks reasonably strong. It continues to be very challenging for us. We've got to make sure that we provide all of our cancer services, ensuring all the right social distancing for both our patients and our staff. So we intend to ensure that we continue that relatively strong performance and move back to target during the course of this year. In terms of Diagnostics, the national target is 99% of patients should receive diagnostics within 6 weeks of referral, and at the end of the year we were 96.17%. We had achieved that standard right the way through the year, and it was only in mid-March, largely as a result of COVID, that our performance slipped. And as I've described earlier on in the presentation, we're making strides to pull all of that back, particularly around endoscopy. If we move on to some of the highlights in the year, it all seems an awful long time ago now, but we did receive a CQC inspection and we received a good rating from CQC. They looked at only a limited number of services. That was an excellent result, and we got our first services that received outstanding from the CQC as a rating, which was end of life. We've continued to build on a track record of many successes across the organisation, supporting and leading research projects, embracing technology, particularly the way that we provide decision support and auditable information about the way we provide care in the ward environment through Nerve Centre. We've worked collaboratively with colleagues in primary care and our commissioning colleagues to put in a teleskin service so that we can more conveniently and for patients provide services to them for skin cancer, a service that has a long waiting list, or had a long waiting list, and we've used technology to allow images to be whizzed to our dermatology teams so that they can accurately triage the patients that have come through the GP route. Continuing with our highlights, we have worked with Health Call Solutions Limited, which was a company that essentially span out of this organisation, and through that company, working with others across the North East, have launched a digital platform to help with the management and care of residents, particularly in our local care homes, and that's helping already reduce hospital admissions. So it's smoothing pathways, and we've seen a big drop in hospital admissions, which is excellent. We signed an Armed Forces Covenant and received a Bronze Employer Recognition Award during 1920, and we're delighted to be able to advise that we've now received a Silver Award. So that recognises the support that we provide to both those that have left and are supporting armed forces currently. So moving on to quality and safety and our summary. So we set our quality priorities out for a 3-year period, and in each of those 3 years we determine targets that we try and meet. We very consciously set those as very stretching targets, and we work with them, with stakeholders, so that they're not just developed internally within the trust, but they are targets that resonate with our communities, our commissioners, most importantly our patients and their representatives. So we have 23 of those, and what I'm going to do is just quickly share with you our performance. So in terms of our patient falls, we had a target for reducing incidence of falls, which we achieved in community hospitals. We didn't quite achieve it in the acute hospitals, the main hospital sites of Durham and Darlington, and that is a main focus of our falls team going forward. The falls team have done amazing work, and they're now focusing on that acute inpatient environment. We delivered on our dementia pathway. We developed a pathway, and we've been monitoring care and including enhancements that we've made to the environment. So we achieved that ambition, which was excellent. In terms of MRSA, we aim to deliver a zero tolerance approach to MRSA bloodstream infections. We didn't quite achieve that. We had 6 of those infections during the course of 1920. In 2021, we're therefore focusing on our MRSA screening and decolonisation, and we're monitoring and auditing our intravenous line care to help improve that over the course of this year. We aim to have no avoidable grade 3 pressure ulcers within either acute or community services. We're delighted that we made improvements with that, but didn't quite manage to achieve that very ambitious target. We're continuing to review formally all patients who have had a grade 3 or above pressure ulcers, so that we can put that learning into practice across all of our sites. We achieved the target that we'd set for maintaining our venous thromboembolism assessment compliance to above 95% and actually achieved 96%. That's good. On our discharge summaries, however, we missed that target slightly. We had an ambition of 95% and achieved 89.5%. We're continuing to emphasise the clinical importance of discharge summaries to our frontline staff, and hopefully we'll see improvement in that over the coming year. In terms of our never events, we actually had 3 in the year in question, 1920, compared to a target of nothing. We had a wrong site prosthesis, fractured neck of femur, a misselection of high strength midazolam during a conscious sedation, and the connection of an oxygen dependent patient to a wall air supply. We've thoroughly investigated all of those never events. They happened in the earlier part of the year, and we've got strong action plans to ensure that they don't happen again. We've indeed to date not had a further never event, but are continuing to rework to ensure that we embed safety, our protocols and learning right across the organisation. We then had success in terms of our LOCSIP standards, local safety standards for invasive procedures that we've been able to introduce across the organisation. So we've successfully completed that programme of work. We've been able to ensure that patients, our inpatients, have been adequately screened for undernutrition, and that where they've needed onward referral, that's been available. We've achieved our ambition in terms of ensuring that patients who are able to choose to have their death in their usual place of residence. We've been responsive to patients' personal needs. In terms of staff who would recommend the organisation as a place for friends and family to receive treatment, we've seen a significant increase over the previous year. It's not quite as high as we would like, but that improvement is being built on with a programme of staff engagement during 2021, and we've seen some opportunities through COVID to really enhance the care that we're providing. It's great that we've been able to meet the target that we set to ensure that staff experience of harassment, bullying or abuse is not tolerated. Clearly we've met the ambition that we've set, but we will not stop with any of those actions until that's eliminated completely. The percentage of staff that believe that we provide equal opportunities for career progression or promotion has improved, and we met our ambition with regard to that. And again, going back to the obligations we have around inequality, that's very pleasing to see. Our friends and family test and ensuring that we get a good response rate to that. That's the way that patients tell us about their treatment and experience in our emergency department. We did get improvements in terms of the amounts of returns that came back, but we're going to encourage and seek more innovative ways to deliver that objective in full as we go forward. And similarly with the friends and family test to improve the response rates to inpatient areas. In terms of our mortality, our risk adjusted mortality, we have achieved one of our targets, but we have made some improvements but not quite achieved our shimmy. We, in terms of that indicator, have been doing some deep dives, looking and learning from reviews of those cases within the organisation, and indeed looking at the way that we're coding that activity. So we would hope that that would improve in line with our ambition during the course of this year into next. Our readmission rate into hospital slightly fell short of our ambition, but we did achieve improvement and continue to focus on those areas. The next set of metrics all relate to A&E, so I've covered those, I think, in terms of that high level 4-hour standard. But when we saw that improvement in those first few months of COVID, that improvement wasn't just within the 4 hours, but was in those sub headings that you can see on the slide in front of you. Moving over in terms of the way our patients value the services that we provide them, in terms of their the way they describe their outcomes. We've not quite achieved that ambition for hips, but we were very pleased to be able to achieve that for knees. You'll see in the maternity standards that we were slightly short of our breastfeeding target, and the team are doing an awful lot to look to consolidate that significant progress that's been made. But it's great that in terms of both 12-week booking and smoking in pregnancy, we were able to do well, as you'll see in those slides, and deliver significant improvements, albeit that we, for the smoking, have a little way to go in terms of our stated ambition. We improved paediatric pathways for urgent and emergency care, and that was something that come out through our CQC previous inspection. And we've been doing an awful lot to learn from the excellent practice that exists within the organisation. We do that well in terms of any lessons that are to be learned, but there's a lot of excellent practice, and our excellence reporting system is now very well embedded within the organisation and provides a huge vat of good practice that we can draw on across the trust. If I move to the financial summary for the organisation, I think that in terms of the auditors, they had no issues with the accounts that we presented and that have been laid before Parliament. We did receive a qualified except for opinion on our stock, and that was because due to COVID the auditors couldn't attend the stock takes, and that similar except for opinion is widely reported across NHS trusts in England, as auditors in other places had similar restrictions. The other thing that it's just worth pointing out is the quality report. Usually our external auditors will do a significant piece of work on a limited number of our quality account indicators, but this year, due to COVID, that work was stood down. So in summary, a clean bill of health in terms of that advised by our auditors. The financial performance, which is on the next page, we are in the accounts, you'll see the surplus of 11.486 million, which is on the slide. We are regulated through the arrangements of which we are part to a different figure, which is the 9.3 million that you can see, the regulatory financial surplus. So in essence, we delivered slightly better than we had planned in a year where we coped towards the latter part with COVID. The COVID expenditure was met in full separately, but it was good financial performance, better than expected by about £188,000. What that meant is we were able to secure all the additional funding that is available when one performs as we've set out to, and that amounted to £8 million. We were able to make capital investments of 21 million. Quite a lot of that went on our PFI estate, but we were also able to move into the second year of a significant replacement programme through a contract that we've got for our radiology kit. So we've got state-of-the-art radiology kit, and that's having a significant and very beneficial impact on the ability that we have to recruit really high calibre staff. Cost improvements delivered £24.2 million. Moving over to the next slide, we have a rating which is called the use of resources rating, and I just need to point out that this is actually 2 in our annual report. For anyone who's eagle-eyed and being able to look at it, it's actually as a 3, so it's an improved position over what is currently in our annual report, and that's because due to additional improvements in our I&E, our capital service cover improved from a 4 to a 3. That's the top metric right at the end of the year. So if you could just note that, that would be fantastic. So I think all in all, a year that we couldn't have possibly predicted at the beginning, a year where we as an executive and board could not have been prouder of the response that our staff made, a year where no doubt time will tell how well we've done, but from every metric that we can see, we think we've served our populations, our patients well, and we thank you all for the contributions that you have made to that performance. We thank all of CDDFT, Team CDDFT, the colleagues that we work with, our governors, FT members, volunteers, the local communities who were so amazing during the height of the pandemic, health and social care colleagues whom we're working more constructively and closely with as each month goes on, and of course patients who provide such a valuable source of information for us to continually seek to improve our services so that we can provide the safest, most compassionate and joined up care to everybody that we treat.
Thank you, Sue.
Thank you.
And I'll pass to Warren, presentation on membership.
Good evening, I'm Warren Edge, I'm the Trust Secretary. It is of course our members in public communities and our staff members who hold us to account and who represent the views of our patients and public in terms of our planning and our services. So important that we keep a healthy membership and we recognise the contribution that you provide. So I'll say a little bit about our membership base and governor activities. I'm joined this evening by our lead governor, Richard Scotton, who I'll turn to towards the end of this section to say a little bit about the difference that governors can make. So our public membership stands at 11,300 members. It's been at this level for several years now, which I'm quite pleased to say is an achievement. It takes significant recruitment effort on the part of my team to recruit new members every year. We insist on doing it face to face because it starts with a dialogue with people who are interested in becoming members and representing views to us, rather than using any kind of agency recruitment to recruit members. Last year we recruited 221. We had to cancel some recruitment events in March due to COVID-19. We always have unfortunately some members who need to leave us during the year, moving out of the area, or who sadly pass away. Occasionally we have people who decide that membership is no longer for them. Usually when we send out the AGM invitations is when we get told about it. The areas of Darlington and Wear Valley and Teesdale, and that does tend to follow some major initiatives that we've had there in the past where people have shared their views. Next slide, please. Our membership goals are to grow our membership, not in terms of for numbers' sake, but in terms of getting real engagement with our communities. That then gives us a strong membership voice to inform plans and services. And we need to increase our membership engagement, something that is a challenge, of course, in the current environment, but for which we have extensive plans in terms of public events, shared events with other stakeholders. So we are active in recruitment, as I've said previously. We recruit through our own sites. We go out into communities, and particularly we've had a lot of success in recent years with further education colleges, where we have managed to sign up a lot of younger members and improve representation from our younger patients, which we're very pleased about. We recruit through our members. We invite members in normal circumstances to our sites for lectures and medicine for members events, for community events with our partners, and have constituency-based communications. We are looking to see what we can do virtually. We're already working with further education colleges on virtual recruitment methods, and we are working with partners such as health and wellbeing boards in terms of how we can reach communities and memberships virtually in the current climate. In terms of the elections that we held during the year, our May 2020 election was paused due to COVID-19, although 2 nominees were unopposed and so were duly elected. The elections that took place during the year, you can see on the screen, we had contested elections at Darlington and Durham side. For Durham City, Hambleton and Richmondshire, Weir Valley and Teesdale, community-based staff, we had candidates who were elected and opposed, and we managed to have a contested election for one of the staff constituencies for AHPs and professionals, and all of those duly elected governors are now playing a very active part on our Council of Governors. So I'll just turn my laptop slightly to allow you to see Richard, who now can talk about the difference that governors make.
The work that governors do, and I pay tribute to my colleagues, have been absolutely critical over this time of COVID-19 on daily basis engagement. But just to tell you a little about what we do, we hold to account the non-executive directors in what they do. But in that way that governors are able to help with the performance of the board and also planning priorities, it means that we, as members of the public, as users of the trust, are able to disseminate that amongst the public. So, for instance, 2 things that we've handled this year has been communicating the issues regarding concessions for car parking, which has made a real difference to so many people. We've been able to bring that for patients, friends, their families, a big thing for us. The impact of service changes. COVID, we could never have imagined just how much would change. And it has been important and incumbent on governors to relay that back to members of the community. So that remembering with that governors do have a proper real voice as a council, reporting back and also helping to influence change for our services. But I say to you as lead governor, please join us. Tell your family, tell your friends, tell people who you think could make a difference in the way that we do things here. And I really do urge you to do that. And with that, I pass you back to the chairman.
Okay, thank you, Richard, for that. We're now moving into the question and answer session, but before we do so, I just want to remind people that we're now closing the live chat opportunity for sending in questions. You can still send in questions until the end of the meeting, but those questions after this point will be responded to either directly or through our website. So we've received 7 questions in all, 3 from governors and 4 from members. So what I will now do is I will ask each of the non-executive directors respectively to read the question out and respond accordingly, starting with Noel, question number 1.
Hello, my name is Noel Scannell. I'm the Executive Director of Nursing. The first question relates to how the Trust adapted to the ongoing COVID-19 reality and through the medium of information technology, both inside the hospital and the wider NHS community, and whether it actually helped or hindered patient care and improved diagnosis and treatment. What I would like to say is at the Trust, we've continued to exploit our current systems and adapt these as far as possible to support the changing needs of our patients and clinicians as a consequence of the pandemic. In some areas, this has highlighted the limitations of our current systems, and where possible or reasonable, we've invested in solutions to overcome or work around these, not least amongst our primary care partners and across the broader NHS network. In the wider northeast of England, we've had the benefit of the Great North Care Record as a cornerstone in supporting and improving the quality of care, including diagnosis and relevant treatments. So the feedback that we've had from our primary care colleagues in particular has been very encouraging. And while we of course would like to do more, and Sue will talk about that in the following question, we believe we've worked tremendously hard and had very good feedback from our capacity to adapt, improve, and collectively work together to improve the quality of diagnosis and treatment for our patients at this very challenging time. I'd like to hand you back to the chairman now.
Lord, question number 2, I pass to Sue.
Thank you. This question is also from a governor, and it is: at what stage is the Trust in implementing its own electronic patient record alongside the patient's charter and their right to access medical records online via various apps? Now, in terms of the patient's charter, that actually requires all GPs to make available to patients that request it their full medical record, which would include anything that came from this organisation, which might come in the form of, for example, a discharge letter. And the deadline for all practices to be able to provide that to patients was earlier this year, April 2020. And to our knowledge, that patient charter commitment has been made good, but patients do need to request of their own GPs permission to access in that way. So anyone wishing to do so needs to contact their own GP surgery. In terms of our own electronic patient record, that doesn't at the minute allow any easy access, and we don't believe that that's the case up and down the length and breadth of this country at least. What we are doing is we're committed to put a new electronic patient record in. We did pause that project for a year as we needed to divert resource and attention to COVID. So we would hope to pick up the reins on that again towards the end of this financial year. That would see us begin to implement in the next financial year. However, I think it's fair to say that the patient interoperability directly with our EPR is likely to be some 3 years from implementation. So at the minute, the access is via the GP record. And back to the chair.
Question number 3.
Hello, a very topical question from one of our governors. How far is the Trust able to access sufficient capability for COVID-19 testing for patients and staff? And how far is it able to support care homes and others with testing? I think it's important to point out there are 2 discrete elements to the COVID-19 testing regime in England. Pillar 1 testing relates to the National Health Service provider sector. That is to say, we within hospitals provide testing to meet the needs of our patients and the staff that care for them. And that's primarily directed to ensure that we are treating patients effectively and we provide the right diagnostic information to the doctors and nurses caring for them. And to that end, we've been very successful. I would have to say we would like to provide testing times more quickly, and that's sometimes a function of testing reagents, which are in short supply, and technology, which is rapidly being rolled out to provide more high volume testing. But if I give you an example of the kind of approach and the capacity that we've offered, not alone do we support our own patients, those inpatients, those coming in for elective operations, but also our staff and the household contacts of our staff in order to keep them safe and continue to contribute to patient care. Primary care staff and their household contacts, our partner Mental Health Trust, Tees, Esk and Wear Valley staff and their contacts, Durham County Council through our Occupational Health Department, Darlington Borough Council, County Durham and Darlington Fire and Rescue Service, Teesside Hospice, and care and nursing home residents who are symptomatic, we test those also. So we have been working tremendously hard. You would imagine there are peaks and troughs. We test about 350 patients every single day. But on the 18th of September, at a time when the schools were just going back, local lockdowns were beginning to bite, we tested 600 patients that day. And that's a great tribute to the fortitude and perseverance of our laboratory staff in the microbiology department, who on that day were supplemented by colleagues from histopathology, blood sciences, biochemistry, and the like. So we are doing very, very well, but I'd like to say that we could do rather more. And indeed, we do have a limited number of very rapid access tests that can turn around a test in 90 minutes, but they tend to be reserved for patients who require rapid emergency surgery or whose medical condition is so precarious that it's really critical that their clinicians find out their COVID status as rapidly as possible. I'll hand you back to the chairman for the next question.
Thank you, Chairman. How is the Trust coping with COVID-19, how many people in the Darlington area were actually admitted to the Darlington Memorial Hospital since COVID-19 began, and how many fatalities in the Darlington area. So I forgot to introduce myself. I'm Jeremy Cundall. I'm the Trust Medical Director. I'm going to take the second half of the question first. We've looked at the postcodes of DL1, 2 and 3 to answer your question. There have been 145 admissions to CDDFT sites by Darlington patients with a positive COVID-19 diagnosis, of which sadly 28 died in hospital. Darlington residents may well have been admitted to non-CDDFT sites as well. Registered COVID-19 deaths for the Darlington local authority residents was 92 up to the 11th of September. This was pulled from the Office of National Statistics data. For the first part of the question, how is the Trust coping with COVID-19? Obviously, the Chief Executive has gone through that in great length. What I would say is, from a staff point of view, we never felt that we were at risk of having too many patients. We never ran out of PPE. The health and well-being of our staff was at the centre of everything we've done and are doing. I'm immensely grateful for the Occupational Health Department and the HR and OD Department for all that they've provided for the staff. Highlights of that are free food, free parking, increased rest facilities, the introduction of the concept of civility saving lives into the organisation, the closed Facebook page for staff to talk about their experiences. We have three levels of support for the staff. Level 1 is access to things such as free yoga and meditation or chaplaincy service. Level 2, an example of that would be a listening ear service. And finally, at the high end would be full clinical psychological support from a qualified psychologist. The health and well-being of our staff will be paramount for what we have to cope with for what will become a very long winter, I'm sure. I'll pass back to the Chairman.
Question number 5, also from a member for David.
Thank you. Good evening. My name is David Brown. I'm the Executive Director of Finance. The question posed by one of our members is, what are the financial implications of COVID-19 for the Trust? And did any of Captain Tom's raised monies ever get to the Trust? If I take the second part of that question first, to date we haven't received any of the specific Captain Tom monies yet. These are currently lodged with NHS charities together, and they will be allocating those funds in the future following a bidding process, which we are part of that process. To date, however, we have received £137,500 from NHS charities from other funds that they had received during the COVID period, and that was received in the form of a grant. In terms of the financial implications for the Trust, during 2019-20, we were able to claim for any additional expenditure incurred due to COVID-19, and that is included within our reported income and expenditure position for the year. Ongoing, as we move into the new financial year, there is a temporary financial regime in place, and that ensures that for the year to date, we have a balanced income and expenditure position at this point in time. That means we've been given sufficient funding to cope with both COVID and non-COVID patients. And at that point, I'll pass back to the Chairman.
David, question number 6, again from a member for Noel.
So this is quite a long question and it's in 3 parts. In August 2017, revised implementation guidance was published in respect of the Accessible Information Standard, DCB 1605, and with special reference to flagging of needs. Part A, what protocols and actual arrangements have been put in place to ensure that disabled people under the Act have been asked to state their needs, not preferences, for communication. The Act required all NHS organisations to ensure there's a consistent approach to the identification of patients, service users, carers and parents' information and communication needs where they relate to a disability, impairment or sensory loss. The Trust Accessible Information Framework Policy was ratified in July 2018 and will be reviewed by the Integrated Governance Committee next year. As a consequence, there is a CPI or electronic flag put on CAMIS, our patient information system, And when a patient or GP informs us of a particular communication need, the CPI on CAMHS is updated. The procedure for this was ratified in May of last year, and once again will be reviewed next year. This information feeds through to Synertech, the company that produce our letters and any correspondence that is sent to the patient then in the required format. This includes the ability to capture blind patients as a flag, and the system can produce the subsequent letters in Braille. Last year, 2 patients received Braille letters, 2 received communication through British Sign Language, and a further 9 patients received correspondence in 24-point font, 11 in 28-point font, and 5 in Read Easy formats. And in addition to that, our nursing management and care system, which is called Nerve Centre, requests specific information in relation to the individual's needs and preferences in relation to communication and information. That is to say, for every patient admitted to the hospital, every nurse is required to assess these preferences, actually their needs. Is a staple or requirement of the nursing assessment framework. The second part of the question asked what arrangements are in place for obtaining patients' consent to pass this information throughout any departments within the trust. Well, for a very long time, we've all sought consent from patients, but under the GDPR, the General Data Protection Regulation of 2016 and subsequent UK Data Protection Act of 2018, there were further rights put in place which reinforced the Health and Social Care Act of 2012. And these under Articles 6 and 9 meant that we were further required to obtain consent before we passed those pieces of information. All of this information, and indeed the answers to any questions that have been put to us, are available in writing afterwards. The third part, I'm getting there, relates to the patient's, the questioner's own personal lived experience, and has asked if we feel the trust is equipped to respond to requests for accessible information. Well, I think I've demonstrated that we are able to respond, but of course I recognise that that may not necessarily be the experience of the questioner here. And although this is not the place to answer individual questions about a person's experience, what I would encourage the questioner to do is to come back to me through the Chief Executive's office or the patient experience team, and we'll happily investigate where we may have failed to meet the individual's expectations. And with that, I'll pass back to the Chairman for the next question.
Thank you, Noel. Final question will pass to Jeremy. It's from a member also.
Thank you, Chairman. So the final question, not having access to the annual report, is there any reference made to the NHS Genomic Medical Service? And if so, please let me know what is the current state of affairs as far as DMH is concerned. The NHS Genomic Medical Service is run from our regional point of view out of Newcastle. We have access to that from a patient point of view to the clinical services, and from the kind of medical point of view to the laboratory services. We are fully involved with that service as is required and have complete access to it when we need to, but we do not run that service. Thank you.
That concludes the questions we received in advance of the meeting, but during the meeting, Jill from our communication team has been collating the questions we received through the live chat, which Warren will now take us through. Thank you, Warren.
Thank you, Chairman. Thank you, Chairman. So we have 5 questions from members of the public. Before I go into the questions, though, we have also had a message that the individual who's provided it, Stephen Gwilliam, who's a scrutiny officer at Durham County Council, has asked is passed on behalf of the Council's Adults Wellbeing and Health Overview and Scrutiny Committee Chair, Councillor John Robinson. Councillor Robinson has previously placed on record his appreciation for all the hard work and commitment shown by NHS staff, including our own staff during the COVID pandemic, and in his absence tonight wanted to reiterate his thanks publicly to all Trust staff. In terms of the 5 questions, there are 2 that are related and they concern our plans previously published for the A&E department at Durham. I'll come to Sue in a moment to respond on that particular issue. There's one in terms of timescales for restoration of services and the potential impact of any upswing in COVID activity. I'll come to Carol to give an initial response to that one. There's a question about how governors are finding innovative ways to engage with the trust and with members during COVID-19. So I will turn literally my laptop to Richard for that one. And finally, there's a question about whether any healthcare staff in our area have sadly passed away due to COVID-19, to which I will come to Noel first of all. So the question concerning the plans for the extension of the A&E department at Durham, as I say, there are two related questions. The first one is, what is the status of the trust plans for the extension of UHND's A&E department in the light of government announcements on NHS investment, and will they be impacted by the change in pathways introduced to deal with COVID treatment and admissions? The related question is very simply, did we get the funding allocation for that extension? So I'll turn to Sue for a response.
Thank you. So our plan to extend the department at Durham UHND, we haven't, to answer the second part of the question first, we haven't received any national funding for that proposal. What we have needed to do during COVID is extend the department in other and different ways. So we've moved into the neighbouring area which previously housed our fracture clinic to enable us to provide those two separate COVID and non-COVID streams through ED that I mentioned in the presentation. We have been successful in securing some money for some redevelopment at a much smaller scale in advance of this winter, and we are in the process of further extending the ED footprint and in particular providing same-day emergency care. So I think the in answer to the question, the department still remains smaller than would be optimal. Its layout is still not what we would design from scratch, but out of necessity, and given that we're hurtling into winter, we've needed to put these arrangements in pro tem. The board formally will at some point in the future need to take a view about the relative priority of ED, and we are continuing to source or attempt to source income streams for it. So I think that probably answers the question, I hope. Warren.
Okay, thank you, Sue. The question, which is also from Stephen Gwilym, in terms of timescales for restoration of services, we've shared potential timelines for restoration previously with the Overview and Scrutiny Committee, and the question quite simply is, are these still achievable, or will they be subject, do we think, to COVID upsurge pressures? Carol.
Good evening, I'm Carol Langrick. I'm Executive Director of Operations with the Trust. Our plans with respect to the restart of services, including the level to which we are able to do so and the timescales have been referenced earlier on in the meeting. We made a cautious start as the demand from COVID has subsided, and are constantly revising and pushing upwards in terms of the services and the volume to which we are able to provide, and that's very much in line with as we have previously reported. However, clearly with the developments in terms of a second wave with COVID, we are having to keep our position under constant scrutiny, and what we will try to do is we will try to maintain our levels of elective and planned activity and all of our services to as much as we are able, whilst we are dealing with the whatever will happen in the second wave of COVID. Clearly our priority has got to be the infection prevention and control within our organisation and within the community. And so therefore, if the levels of COVID continue to rise, we could reasonably expect to see some pressures in terms of our ability to provide services, the elective planned services, hopefully not to the same extent as we saw in the earlier first wave, but this is something that we will have to review as we go on. Thank you.
Okay, thank you, Carol. So the next question, for which I will turn to Richard, is the questioner is keen to know if governors have found innovative ways to engage with members and with the trust during COVID.
I think these have been difficult times. It's very interesting that the mother of invention, as they say, has brought many governors to social media. The social media quality of, for instance, boomers like me on Facebook, but for younger folk, where we've done your Instagrams and so on and so forth, and it works two ways. It's us keeping an eye on what folk are saying and being able to respond, but also as governors being able to reinforce what the trust is giving out, and for us to put that in our own social media settings, but also to disseminate that through other settings, your other like the Rotary clubs and likes of those organisations which have a really solid community base. So that's the first. The second is we have two governors now who are our colleagues at Healthwatch, and Healthwatch have a fantastic network in which to speak to people, hold folk to account. And I know from the work that they've been doing, which we're enormously grateful for, and to, that they have been putting out information and garnering information. I know my colleague, Dr. Robert Upsall, is listening in on this now, and those of you who want to talk to the likes of what that organisation has done, I know Robert would be delighted to speak to you.
Okay, thank you, Richard. Now, what was the final question, but we had a very late entry, so just to forewarn Sue that I will come to her for what will be the final question, which does concern how we the controls that we have in place in terms of monitoring staff working from home. But the penultimate question, therefore, which I would direct to Noel, is: did any healthcare staff die in our area from COVID?
I can only really speak with authority about our own staff who treated in our own hospitals. I would say that 3 members of staff have been so seriously ill with COVID-19 infection that they've required hospitalisation. 1 member of our medical staff received treatment for a short period in our intensive care unit, had further recovered on the ward and happily went home. A member of nursing staff required treatment for several months in intensive care in the ward and followed further rehabilitation at Bishop Auckland Hospital, then walked out of the ward after extensive treatment and rehabilitation. Sadly, a 3rd member of our staff, technically in the employ of our private finance initiative subcontractor, did pass away after a period of treatment in the intensive care unit. Of course, as far as we're concerned, that member of staff is part of the NHS family, and we would answer the question in that spirit. And it's sad to say that we have seen large numbers of healthcare workers pass away during this pandemic, and we, like very many, have experienced that kind of very, very sad event.
Okay. Thank you, Noel. So the final question that we have just received is: how do we monitor work that staff do when they're working from home, and how do we guarantee that they observe the required levels of confidentiality? So,
thank you. So I think the first thing is that we are operating flexible policies to allow staff to work from home where that is appropriate, and where that is appropriate would include when we can be confident in that individual circumstance that there wouldn't be any compromise of, for example, the confidentiality as the questioner has raised. So if that couldn't be guaranteed because of the circumstances in which the person would be intending to working from home would not be an option for that individual. We use a lot of IT, and the way that we can we have quite good oversight about what staff are doing through Trust IT, so that's very well regulated, and we have policies that cover everything from what one is able to move out of the organisation's environment in terms of paper records and what one isn't. So unfortunately, not everybody can work at home for exactly the issue that's being raised, because we, amongst other things, need to be able to ensure that all our patient data and other data is kept confidentially. The policies that we have both within the trust apply equally to our staff when they're working in whatever environment may be the case.
Thank you, Sue. I think that means that we've responded to all the public questions on the night. Now, hand back to the chairman.
Thank you, Lauren. It's just now time for some concluding remarks, and I would like to just start by following up from Noel's comment about members who have been affected by COVID-19, and our thoughts are with those families in the community who have been severely affected by COVID-19. They are part of our community. We are part of their community. So our thoughts are with all those who have been affected by that. As you've heard this evening, 2019-20 has been a difficult year, but actually 2020-21 is even more difficult, and we are only partway through it. But because of our resilience and because of all the thanks that Sue mentioned earlier on to everybody that works within our community, CDDFT, the kindness we've received from community, our governors, our trust board and so forth, we have to remain resilient in seeing this through to the bitter end. It won't be easy, but we will do our absolute best to keep our staff and patients safe, and it's incumbent upon everybody within our community to do the same thing. So in terms of concluding this evening, I would like to thank our communication team, that I believe this has gone well. I can't recall any hiccups. I might have caused a few, but overall I think the event has gone very well. So many thanks to our communication team for allowing this to happen, and just to wish everybody in the community to remain safe, and for us colleagues a safe journey home. So thank you.